SAGES Stories.
Welcome to today's episode of SAGES Stories, the official podcast of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. Please make sure to hit the like button and subscribe so you can stay up to date with our most recent episode. And enjoy the show. Hi, everyone. Welcome to episode 32 of SAGES Stories, where we shine the light on some of SAGES' most impactful leaders. I'm your co-host, Dr. Jenny Shao from Ann Arbor, Michigan.
And I'm Dr. Kevin El-Hayek from Cleveland, Ohio. So much in line with our last episode, we're going on another presidential tour, and we are excited to be interviewing another prominent leader and president-elect of the European Association of Endoscopic Surgery, EAES, Dr. Nicole Bouvy. Professor Bouvy, is it Bouvy or Bouvet?
Bouvy.
Bouvy, yeah, mais bien sûr. Is a world-renowned leader in minimally invasive and endoscopic surgery. She is a true triple threat. In addition to being president-elect of EAES, she holds many additional leadership roles, is a surgical innovator, a grant-funded researcher, and has almost 300 publications to her name. Can't wait to hear your story, and welcome to the podcast, Dr. Bouvy.
I'm so honored to join your podcast. It's a great initiative. Thank you.
Yeah, well, honestly, the honor is really ours to have you here. And I can't wait to delve into some of the questions, to get to know you, your journey in surgery, and to hear your SAGES story. So to get us started, can you tell us a little bit about where you're from and maybe some impactful moments along your journey and surgical career so far?
So I grew up in Amsterdam. This is the capital city of the Netherlands. And the Netherlands is a small country in Western Europe. It's known for its canals, historical architecture, bicycles. And you can think of a mix between Boston, walkable distances, historical sites, San Francisco, progressive and diverse, and New Orleans, vibrant nightlife. And perhaps many Americans know Amsterdam for its airport, because it's a major international hub to get into Europe. So I grew up in Amsterdam in a family of 6. So my father, my mother, and 3 brothers. And with these 3 brothers, we were in 4 years. So my mother really did a great job.
Wow.
Yeah.
Where are you in that line? Which child?
The second one.
Second child. Great.
So I grew up playing football with my brothers. Was very honored that I was the only female player in our school football team. My father also was a surgeon, and my mother a child psychologist. So they did not have a lot of time for us. So we were the 4 of us together. Great team. That's why I probably started my preference for teamwork. Well, then I had, of course, high school in another city in the Netherlands. My medical school was in Rotterdam. That's the harbor city. So a lot of stuff coming from the US enters Europe via Rotterdam, the biggest harbor of Europe. And then did my PhD. A lot of Dutch surgeons have done PhD studies, because to enter your surgical residency, it's important to show that you can also do research, and then you can start your medical residency program. That's
I've
why.
heard it's actually very competitive. Is that true? Like the system in general, it sounds like there's only certain spots to go through as a surgeon. And of course, I learned this from my great friend Ava Derenberg, but
Yeah.
she talked to me a lot about this. So it's definitely very different than it is here there, in the United States, I think.
Is it? I thought it was also very competitive to become a surgical traineeship, or isn't it?
Well, I think that the PhD aspect is not there here as much as it is, in my understanding, in the Netherlands. So it seems like a lot of the surgeons I know from the Netherlands have both their medical degree and their PhD, versus in the US that's relatively uncommon. I mean, there are a few, but most do undergrad and then medical school, and then it is competitive to get into surgery, but it just seems like the pathway is different, and you all do much more research than we do.
Yeah.
How
Yeah,
many
indeed.
years? How many years does that take? Usually, the PhD.
Usually, the PhD starts already during medical school, and then takes another 3 years. Sometimes 2, sometimes 4, but mean 3. And that's also a blessing for a lot of professors of surgery, because the PhD students are very motivated to do a lot of research to become into this surgical residency program. And that's why, a lot of research comes from the Netherlands, actually, I think. Yeah.
It is a research powerhouse. I think so much of our level 1 data that we use for some of the more complex diseases. I'm a pancreas surgeon, so obviously I rely on a lot of the data out of Netherlands. So it's just an amazing powerhouse of research.
Can I
And
ask what you wrote your thesis on? I'm kind of curious now.
yeah, so to come back to the research, the trials. So the trick is that we are a small country, but all the hospitals love to work together. So there's a lot of collaboration, and that creates big data and randomized controlled trials. So my PhD was on the metabolic and oncological consequences of laparoscopic surgery. At that time, a long time ago, 1991, laparoscopy just started. So we started doing laparoscopic cholecystectomy and started exploring more advanced laparoscopy. And one of the first to start was laparoscopic colon surgery. So in a hospital nearby, we did 20 laparoscopic colorectal resections. And in 3 of those patients, we experienced abdominal wall metastasis.
Oh, port site mets. Yeah.
Port site metastasis. I do not know if you still know that, but at that time, this was a serious problem. It almost killed laparoscopy, because we thought it had something to do with the CO2 pneumoperitoneum, or we could not explain why this was happening. It was an interesting period, because that was the start of collaboration worldwide of endoscopic surgeons. So we developed a laparoscopic rat model, so a small animal. And in this animal model, we started injecting tumor cells and getting pneumoperitoneum, getting direct tumor wound contact. And we did a lot of research on that topic together with 2 members of SAGES, Larry Whelan, I think he's in Columbian University now, and Mark Bessler, also one of the pioneers of nodes surgery, and surgeons from Belgium and Germany, and we had yearly meetings to exchange what we found out to be the explanation of the development of these port side metastases.
Wow, that's fascinating. So that preceded your residency, is that right? You did this so you kind of started your PhD and then did your thesis prior to residency in general surgery? During, or was it during?
Together, yeah, indeed.
Together. Okay.
2 years full-time animal experiments, and then
residency.
Residency.
Wow. Yeah. I think there's something different in the water in the Netherlands where you're able to do both clinical volume in a residency program and high quality research like that. It's quite impressive, and we've had a bit of a shift in our podcast to hearing some different international voices and experiences, and how that differs from what we have here in the United States. And obviously SAGES is a very international organization. We recently interviewed Professor Yamamoto from Japan and heard a very different perspective as well. Kind of following along with your work in your PhD, what did you end up deciding to go into for your clinical practice, your specialization? And then maybe I think you've already alluded to how you got involved in SAGES, but talk a little bit about that next phase, your clinical practice, what you specialized in, and then your introduction and involvement in SAGES.
So during this PhD and during this evolution of surgery, revolution, so coming from big surgeons making big incisions, going to minimal invasive surgery, it was great to be part of this revolution. So I loved innovative surgical techniques and making less impact, less trauma to patients by surgical procedures. So at that time, we explored many new procedures. So I was part of the first laparoscopic adrenalectomy introduced in the Netherlands, the first laparoscopic splenectomy. At that time, EARCAT started. I do not know if you know that, but this institute helps to develop surgical techniques and is now in many places in the world. But at that time, it was only in Strasbourg, in France.
Yeah, we just had Dr. Brent Matthews on and talked a lot about the new EARCAT in Charlotte that's opening. So this is timely that you bring up some more about that.
So at that time, there was a website called Web Search. You had to pay $300 for that, and then you had the library of all laparoscopic procedures and all the pioneers doing something, all the cowboys who did something for the first time were invited at EARCAT. They put their videos, surgical videos with explanation on how to do it on EARCAT, and literally in our ORs. We had this video playing and did our same procedure in our hospital room. It will not be allowed at this time, but at that time, that was the way we introduced laparoscopic surgery in our ORs. So very interesting. And then, you were not you were not trained being a colorectal surgeon or a pancreatic surgeon, but you were trained to be a laparoscopic surgeon. So I was quite a general surgeon performing splenectomy, Nissen fundoplication, colorectal resections, hernia surgery, all in a laparoscopic way. thoracic sympathectomy, all procedures that were able to perform laparoscopically were performed by me. And still, I love to be quite a general surgeon and to do a lot of those procedures who make the impact for our patients less than open surgery.
I love that. That sounds like a very broad-based MIS practice and just a great mix of different cases. I'm sure for trainees that are on this call, they're probably all wanting to come and train with you because you do so many cool things. And so I guess one question I had for you, seeing as you were sort of there for the beginning of the laparoscopic revolution is, with all of this new developing technology, and I think it's still very relevant nowadays, right, with robotics and AI. I think the conversation is still the same. Like, how do we keep our patients safe as we innovate, develop new techniques? Can you give us some advice from sort of your lived experience and how we can continue to accomplish this?
So I'm very happy that the training programs are more structured by societies like SAGES and EAES, because at that time, sometimes when I look back, we were kind of cowboys. So to structure training programs is very important, I think. And that started with the introduction of robotic surgery. So I was happy to be the first to operate on a 4-armed Da Vinci system in 2003 in Maastricht. And that was also one of the reasons for me to go to Maastricht. So they asked me to come there to perform laparoscopic surgery. And it was quite a different place than Rotterdam in the Netherlands. So I said,
was that the Zeus platform?
No, already the intuitive platform.
Oh, okay.
This was the old, like the SP, right? Is that from 2003? Or sorry, not the SP, the SI.
And not even earlier.
I think it's even before that.
Oh, before the SI. Wow.
Yeah, this was the S platform then, right? I think it was
or it did not even have the letter.
It didn't even have a name. It was just the Da Vinci. Yeah, okay.
It's a 4-armed Da Vinci. And so I was really happy to go to that city in the Netherlands, the older city, because they bought me the robot. And then from 2003 till 2012, I tried all kind of laparoscopic procedures with this robotic system, doing all kind of trials with it, but I did not see an advantage for the patient. So in 2012, I said, okay, let's do one more research project with this robot to see if there are advantages for the surgeon to operate with this system. Because obviously, as a surgeon, you feel quite relaxed. So we looked at heart rate variability and all kind of stress factors for the surgeons. And indeed, there was an advantage for the surgeon to operate with this Da Vinci system. But still, there are not many research projects that can show an advantage for the patients to be operated with the Da Vinci robot. So I'm a bit concerned because the environmental impact of doing surgery with the robotic system is quite more than doing laparoscopy or open surgery. I do not think that we should go to an area that we cannot even do simple laparoscopic surgical procedures without a robotic system. So I was shocked during SAGES to hear that some surgical residents could not even do a laparoscopic cholecystectomy laparoscopically, but they need already the robotic system to do that.
Well, it's really interesting. So I recently taught a robotics course at Sunnyvale in the headquarters for Intuitive, and they had this map on the wall, which was really, really interesting because it kind of pinpointed where they had robotic consoles across the world. And so in the United States, I'll have to show you this picture, but in the United States, you basically have consoles everywhere. But if you look to Canada, and Mexico, our neighbors, the number of consoles dramatically decreases, right? So maybe the country only has several in, pretty large cities. And then when you take that more worldwide, I think there definitely is like a very huge disparity about access. And I think that's something that, we often talk about in robotics, and perhaps not a conversation that we have here in the United States as much, just because we have more ubiquitous access. But I do think globally, this is something that probably other countries and healthcare systems care a little bit more about. So I think it's a really, really great point that you bring up, and probably just good awareness for our listeners to just kind of be aware that these things do exist and that these are considerations that people potentially make worldwide when they're thinking about care and how they take care of their patients.
Yeah, I mean, I actually had two kind of conversations in the last week that will continue to make you somewhat saddened. One was by a surgeon who, who wanted to do some global work, but recognized that really the practice that the surgeon had shifted almost exclusively to robotics, and felt like that they couldn't provide that care because they were so reliant on the robotic technology. And I'd known the surgeon for years and know that they do have a heart to go abroad, but it was a really touching moment. And then the second was about another surgeon in the area who had multiple patients who were referred where there was a problem with the robot, and the surgeon couldn't complete an operation such as an inguinal hernia, and because that they referred the patient. And I think it is an important lesson about the reliance on technology alone to do what we should be trained to do using different concepts, including laparoscopy, including open. And I think it's just a really, really interesting phenomenon that it's, as Jenny said, pretty much exclusive to the United States of America when you think about people who just have access to one platform, namely the robot. And I think it's going to be a continual issue with our younger surgeons, and you will meet more and more surgeons coming out of training who may have not even done anything laparoscopically.
So I kind of want to get your thoughts on this. But, I think we've been having this conversation for a while. And even though I didn't graduate from training that long ago, I remember when I was a resident, there was this kind of idea that maybe minimally invasive surgery and doing everything minimally invasively wouldn't train residents and fellows well enough to do open surgery in case you couldn't do something minimally invasively, right? We talk a lot about decreasing numbers and open cholecystectomies, et cetera, et cetera. So part of me almost wonders, like, are we just trading like robotics for laparoscopy? I mean, is the same conversation still happening except with robotics versus laparoscopy? I think it's a really interesting, evolving conversation that I think really has been going on for a while. And I think it kind of goes to the heart of what we're talking about, right? Like, so how do you keep people safe as you develop new technologies, and how do you adequately teach and train people, which I think we're still learning a lot about in the current climate.
Yeah. So I think perhaps it's also good to realize that in the 90s, we surgeons were laughing at the urologist because they were not able to remove the prostate in an ordinary laparoscopic fashion because they were not so handy as we surgeons. So they needed a robot. And well, I'm sure that you all have experience with the robotic system, and you have the same idea that it's much more easy to do it with the robotic system. You do not need really advanced surgical skills to do surgery with this robotic system. So perhaps that can convince them to do a proper surgical training. And I'm not convinced that if you can only do surgery with the robot system, that you can also do the conversion, as you said, indeed. Huh? So yeah, that's tricky.
Kevin, I think you're on mute.
I am. You're right. I wanted to follow up on Jenny's last question, which is your work with Surgeons of Tomorrow, this initiative that seeks to prevent surgical complications in patients. Can you tell us more about this and how you became interested in this field?
So Surgeons of Tomorrow, yeah, what I mean with that is perhaps we as surgeons cause a lot of complications like hernia, anastomotic leakage, adhesions, and they're all problematic for the patient. So I have the idea that we do too many procedures. So the indications is very important to first do a good selection of patients. So for example, we stopped doing incisional hernia surgery in patients with a BMI above 32. And first, those patients have to lose weight, and then if they're with the BMI below 30, then we do surgery on them, because there is no risk of incarcerations of small intestines in those patients. Alone the greater omentum is incarcerated. So, and for example, if a patient with rectal cancer with ileostoma has to be reverted, then we say, okay, we can only do this if you lose weight, if you start working on your condition and stop smoking. So only do necessary things. And in the development of innovative surgical techniques, we focus on a medical need. So there has to be a medical need for this development. So if there's no medical need, do not develop it and do not bring it to the market. And also sustainability has to be taken into account. So if it's not sustainable and there's no advantage for the patients, then do not develop this. So we are in constant contact with industry to develop or not develop special things, and also with our technical universities. So that's interesting, I think, and important.
Yeah, I think one of the conversations I have with my trainees often is even thinking about, just because we can do something, should we do it? And I think that's probably the hardest decision to make as a surgeon, right? Is whether or not you're going to offer somebody an operation, especially I think in the world, if you're just doing truly elective surgery, which as a hernia surgeon, I mostly do like 95% elective operations, right? And so I think to your point, this like idea of prehabilitation, optimizing our patients, getting them into this best condition possible, I think is really, really important. So you mentioned something that I really want to ask you about because I think it's super cool, is this sustainability idea. I think you recently received a grant for this project. Is this project Carefree, like creating a healthier environment for future patients? So I'd love for you to talk a little bit more about this project. It's very clear that, you're passionate about sustainability, maybe sort of your interest, how you got into it, and sort of what projects you're working on right now with that.
Yeah. So thank you for asking, because I'm really passionate about this. Because the healthcare sector causes more pollution than, for example, airplanes or so. So 8% of the global of the greenhouse gas emissions are caused by the healthcare sector in Europe and in the US, perhaps in the US even more. And it cannot be that on the one hand we try to make patients better, and on the other hand we destroy the environment for future patients. So because of global warming, there are many people in the US dying because of heat stress or air pollution or unhealthy environment related diseases. That's clear. It's published in the Lancet and many other places. So we really have to feel responsible for that. And 25% of this 8% comes from our ORs, and mainly from minimal invasive surgery, because a lot of disposables are used during the surgery. And for example, in our ORs, the air refreshment cycles are continuously getting fresh air, humidified air, 24 hours per day, although we are not operating in these ORs. So there is a lot of low-hanging fruit to reduce this impact on the environment. For example, we can also better communicate with our anesthesiologist, because inhalation anesthetics like desflurane, isoflurane, they stay in the atmosphere for many years, more than 100 years. So the global warming effect of using those anesthetics is enormously. So we have to stop them now, because the cumulative effect of it will last for many, many more years.
I did not know that. That's really interesting.
Yeah, and
I
there's a
had no
great
clue. Wow.
yeah, there's a great alternative with propofol. So we can use that, and also the air refreshment cycle for laparoscopic surgery, for example, can be out. This is not necessary. If you make such small incisions, these keyhole incisions, they do not need an air conditions where chips can be made, for example. And that's the way we use our air refreshment cycles in the OR at the moment. So what we did is a very interesting comparison between all the about 80 countries in the world, how they performed their laparoscopic cholecystectomy and their complications, and what was the waste of their surgical procedures. So that differed from about 12 kilos of waste in the US till 200 grams of waste in Bosnia, an Eastern European country. So even surgical gowns, dressings, gauzes, they were washed after surgery and reused. So, well, it's very important to see these differences and to learn from each other. And we also looked at complications, for example, infections. And there was not a difference at all in complications in between these 80 hospitals. So probably we do too much.
Yeah, that's really interesting. You can take it to the next level to the African continent, for example, where they have a common saying there that there's no such thing as a single use device. They will use the devices until they break, including a lot of what we use as single use devices. And while I haven't done the scientific rigor that you all have in what you've just described, I can tell you that in that type of practice, there wasn't a noticeable increase in wound complications, infection, and things of that nature. And I think we do kind of you know, overreach in terms of the sterility side, and it is at the expense of tremendous waste here in the US.
I
So
actually have a question for you about that. So with these initiatives that when you're trying to bring change to the hospital systems, did you receive a lot of pushback from hospital systems? How easy was this to implement? Because I think at the University of Michigan, we just started recycling in our operating rooms, which was really awesome. But at the same time, I think that's just the one really small thing that we're starting. So, but I can see that like on a system level, if we want to change all these things, it may take a lot of effort. So was it really hard to convince, leadership and healthcare systems to care about this and to implement it? Or I'm just kind of curious for
yeah,
our listeners and for me.
so it was. So I was looking for the influencers. So for example, the Dutch government. I came into the board of one of the largest Dutch healthcare insurance companies, the non-executive board, in the Dutch Surgical Society, in our hospitals. And I was telling this story again and again. And then, of course, at the European Association of Endoscopic Surgery. Well, what I experience at the moment is that I started 5 years ago, but now we really have the wind in our backs. And many people realize, also because of a lot of environmental problems, floatings, heat stress, that something has to be happened. And also, for example, ground substances, they really become scarce. So we have to go from a linear to a circular economy. And we can do that by using the 10R ladder. Have you ever heard of that? So a lot of people a few years ago thought they were really good for the environment if they recycle things. So they came and get their plastic bottles to recycling. But if you look on real impact in this 10R ladder, then you have to go to refuse, reduce, reuse, but not at recycle. So instead of using this plastic bottle, take your reusable cup with you, and you do not have this problem. If you think of a surgeon and you think of refuse, then the most impact we can probably make is by making proper indications for our surgical procedures. So what we learned from COVID, we did a really big survey on that in the Netherlands, probably also in the US. We made the shift to do only oncological procedures. And not elective hernia surgery or so.
We did, yeah. We did a similar. It was only trauma,
Trauma and
oncology.
oncology.
Yeah.
Yeah. So you, as a pancreatic surgeon, what we found out that only 15% of the patients survived 1 year. The pancreatic patients who
Wow. Wow.
during
That's
COVID.
really.
So now we learn from these lessons, because there is of course there's a war threatening now in Europe, and with the NATO probably we are now making preparations for a lot of victims coming in from the Ukraine that have to be taken care for, and can be more or less the same situation like we had in COVID. So we're now working on lists on who to do surgery on and who we should not do elective surgery on. And there are some shifts, lessons learned from COVID. So, for example, pancreatic surgery is one of those types of surgery that will be lower on the priorities than
Wow.
surgery.
Wow.
That's
That
such
is
an interesting.
fascinating.
Yeah, that's so interesting. I feel like because I feel like during COVID, we definitely had a triaging system. I think, I don't want to say we rationed our healthcare a little bit more carefully, but I definitely think with some scarcity of resources and protective equipment, I feel like we were more thoughtful, perhaps, of, and maybe sometimes more realistic with goals of care and the types of care that we offered. So it's really interesting that you bring that up now, and how even thinking about the global context of what's happening in the world, that this may be something that, even though there's no pandemic, people in Europe are facing.
And also
Yeah, I mean,
we
oh, go ahead. Yeah, I mean, we feel we have unlimited resources in many respects in medicine and in surgery, but certainly in the United States. And we did learn a very hard lesson in those first few months and even that first year, that it's not unlimited. There are limitations, and we still feel that effect, not necessarily from a material standpoint, but from a personnel standpoint. And I think we can learn, as you said, about some of the interventions that you've incorporated in the in the European context. SAGES, as you know, started a sustainability task force, and Dr. Shanita Johnson, a former SAGES Stories guest, his mission is to tackle some of these exact issues. And you've had some other innovations, including some transoral technologies, biomaterials to decrease risk of anastomotic leakage, slow release intra-abdominal chemotherapy delivery methods. I mean, you've really expanded this to a way that many are. I mean, it's almost like science fiction when you look at it. But tell us about some of that technology and how you're implementing that.
So the red line through all the drives to develop these technologies is to make surgery less invasive. So if we can do it transorally, then you will avoid incisional hernias, and you avoid the development of adhesions. So also adhesions is a topic that is underestimated, I think, by surgeons. And also underestimated the consequences for patients with chronic pain. So I'm very happy that we now can look throughout a belly without opening it to see if a patient have adhesions. So what we did is we developed an MRI scanning with movement of images, where we can see if small intestines stick to the abdominal wall or stick to each other, to see if a patient has adhesions. And we are developing a program to do surgery on them and to use barriers to avoid getting new problems with these adhesions.
That's really cool. I feel like the only thing I really know about is like Sepra film. Have you guys developed anything that's different than that you feel like works really well in this context? I'm just curious.
Yeah, so Sepra film works quite well, but it's hard to apply for laparoscopic surgery. So this hyaluronic acid layer that's perfect. So they're developing now a device to also apply it laparoscopically. But for laparoscopy, icodextrin adapt. Have you heard of that? It's the
I
same.
don't think so.
No, I have not.
We haven't heard of it.
It's the same solution that
You're
is used.
teaching us a lot today.
It's the same solution that is used for peritoneal dialysis.
Okay. Oh, okay. Okay.
And that's
Yeah.
icodextrin. So
Okay.
2 versus 4%. And this solution stays in the abdominal cavity for about 4 days. And we know that the first 3 days, the most tricky adhesions develop because of blood clotting and that kind of things. So if you do adhesiolysis, elective adhesiolysis, you can leave that because it's a solution quite easily via trocar or whatever. And also, if you do adhesiolysis for small intestine obstruction, then I think it's necessary to leave this, and we do not do this, but you can reduce the number of de novo adhesions with 50%. So every week we have 3 or 4 people entering the hospital with small bowel adhesion obstruction. Probably you have the same. We lose
for sure.
but we do not leave a barrier.
No. And it's actually the funny conversation you have with the patient, and you say, you know, the treatment is also the cause, right? We're going to do an adhesiolysis, but surgery causes adhesions. And I agree. I think, you know, we've tried to create like a slurry of the separafilm and sort of apply it, but you're right. It sort of just sloshes about. It doesn't seem like it's a good material to apply laparoscopically. So that seems like a really interesting product that could impact thousands of patients a year, I would suspect.
Just a technical question out of curiosity. So if you leave the solution for 4 days, do you then have to drain it out through like a drain, or you just leave it and the body absorbs it kind of like it would for any fluid? Yeah,
indeed.
that's
So
really cool.
It's absorbed by the lymphatic system and not by the blood vessels. So what's interesting, if you compare countries around the world, so you had this interview with a surgeon from Japan.
Yes.
In Japan, they are the surgeons that use these barriers most.
Really?
Yeah.
Wow.
They really want to do perfect surgery, and they do not want to be loved by another surgeon if there's a operation for another indication or whatever.
Do they do it de novo, like for any of their operation? Really? So they do a big cancer operation and they put adhesion barrier.
They do not want to leave any
Adhesions.
I actually
Wow.
now wonder if there's a study looking at, you know, whether the incidence of operative small bowel obstruction would be lower in a country like Japan versus the US for similar surgeries. That could be really an interesting idea to explore. Because I feel like one of the things is we just and maybe I just don't know the literature, but I'm not sure that there is a lot of good literature out there on this as to what prevents this. But that is really food for thought. I'm gonna have to look into this.
Well, and I would say that, you know, it's you all have gone back in after laparoscopy. The adhesions are minimal when you do minimally invasive surgery. I mean, there might be at a port site or something of that nature, but this would be more applicable in my mind in places where you're doing a lot of open surgery. But it sounds like this is going on even in laparoscopic surgery. Is that right? And wow, yeah. So I mean, it's such a rare occurrence in laparoscopy and robotics, but if it reduces it to 0, that's going to be remarkable.
Yeah, but not to 0, 50%.
Well, close to 0. Close to 0. It's already close to 0, though. I mean, with laparoscopy, the adhesions are pretty minimal. They're pretty minimal.
We did a very interesting research on that in Scotland, because the main problem is that people who present with small bowel obstruction, they do not mostly present in the same hospital that they were operated for the first time. So that's why there is this big denial of surgeons that this is a thing. In my patient, it does not appear. This is not the thing. But what we saw is that there is a difference, of course, in laparoscopy and open surgery, but still after laparoscopic surgery, there's 4% incidence. And even going to 10% is in surgical procedures that are performed in the retroperitoneum. So pancreatic surgery, aortic surgery, open surgery, or for example, subtotal colectomy for Crohn's, for ulcerative colitis. Those show incidences even up to 30%. So that would be great to begin with those type of surgeries.
That's really cool. That's definitely food for thought. So I want to pivot a little bit and ask you about your leadership journey in surgery. So if I did my research correctly, I believe you were the first female member of the executive board of EAES, and I think the first upcoming female president. And so I think from one female surgeon to another, I think sometimes these glass ceilings can be pretty difficult to break. And so I'd love to hear a little bit about some advice you may have for our listeners on how to achieve this or even just ascend the leadership ladder.
Yeah, well, probably you know better than me, because to my opinion, there were female presidents already for 20 years or so at SAGES. So that's good. Yeah, in Europe, we are far behind. So visiting some Eastern European countries, they do not even have female surgeons yet. So that's a hard job to catch up. But I think, yeah, we have to be an example for them, that this is possible. And I feel that we can inspire female future surgeons by taking these roles. So that's good. Well, I'm lucky because in the Netherlands, at the moment, we have 50% female surgeons. When I started in my university hospital in Maastricht, I was also the first female surgeon. I was happy to be raised in between three brothers and with a father who was a surgeon too. That helps probably. So, yeah.
I think some of that is definitely understanding the culture, right? And sort of being prepared to kind of go into maybe an environment where people think and operate a little bit differently. And I think one of the things sometimes we talk about in surgical culture is that if you're not used to it, it can definitely be a culture shock, because there's so many things that I think we do that we don't explain to people outside of our specialty. So I can imagine that as a student coming into surgery for the first time. I mean, I still remember when I was a medical student, I think that was definitely true, where you felt sort of out of place, you weren't really sure what to do, and nobody explains the rules to you. It's kind of like going into a foreign country and just having to figure it out on your own. So I definitely think that can make things challenging. And I think, like you said, having the appropriate mentors and sponsors and really being an ally for and supporting other people is really great.
And the other thing that is very important that's now really a big topic is undesired behavior. So we really address that. So if you feel that that you're not taken care of in a proper way as an intern or surgical residents, this can be addressed, and there is really education on that. So that also helps with this behavior.
Well, I'll add my congratulations to you breaking the glass ceiling there, and I hope that it's the beginning of many fractured glass ceilings over the course of the next 10, 20, 30 and beyond years. We like pivoting, so I'll add another pivot. Your surgical career and life speak for themselves. They're fascinating and continue to really inspire. Maybe tell us a little bit about your life outside of surgery. What are some of your hobbies? What are some things you like to do for fun?
So as a surgeon, you cannot have hobbies, huh? No,
Not true. Not true. Not
Work-life
true.
balance.
Yes, not true.
So I have a bit of rare hobbies. I'm a sheep keeper, and
How many do you have?
at the moment I have 30.
30
30.
sheep. What? That's
Wow.
amazing.
They were just giving birth to lamb, so I had
The
12.
lambing, right? Isn't that the lambing? Isn't that what yeah.
And I'm a beekeeper. So yeah,
Nice.
that really makes my heart beat. Also, nature. I think yeah, bees are very important to protect our nature and biodiversity. And I love to take pictures. I'm a photographer. Yeah.
Do you have so do you have a farm then, I'm assuming, and you have these or they graze out and you know, how do you handle all I mean that seems like a lot of work.
Oh, it is quite okay. So lamb take care of themselves. Petzilla visited my farm, and I have
Oh,
great
she
pictures
did.
of, yeah,
That's
I
great.
have great pictures of a pet holding a lamp. She was
Oh my
really
gosh. We need
Oh,
to
that's
post
great.
that to the show
Yeah,
notes.
we might
You're gonna
need
have to
that.
send that to us.
Yeah, we might need
on the
that
center.
picture.
Yeah,
Yeah,
yeah.
we might need that.
And I'm very happy to have 3 children. But at the moment, I do not have to really take care of them because they are 25, 23, and 20. And my husband makes this all possible. He is into finance. The good thing is that if really the shit hits the fan at our house, then he was always there to help, and he was a bit more flexible than I in my hospital and surgical profession. So I would advise not to have 2 doctors in the house if you can choose. Do not fall in love with another doctor. Try to find another.
Love knows no boundaries, Professor, as you know. Love knows no boundaries.
But it makes it easier. It makes it easier.
Yes.
You don't have two doctors. Also, if you have the schedules with your duty and so, and it's also more fun to have another profession in the house because then your partner can be impressed by your stories that you take to
Right.
the hospital. And I can be impressed by the financial world
Yeah.
that he's taking
Yeah.
home.
I love
Yeah.
that. That's such a great shout out to, I think, under-recognized people who support surgeons and other physicians. I definitely think that for all of us in this profession, we have really amazing, family and partners who sort of
Yeah.
keep our lives afloat, as we
Amen.
go out there and do everything. So I think that is definitely so true. So I think we're approaching time, and I can honestly say for Kevin and myself that it's been really awesome to have you on the show. I feel like you have so many great insights into things that maybe and different perspectives too that we don't often, talk about here in the United States. So it was really amazing to just kind of hear some of your stories, your innovations and research projects. I think hopefully we're all leaving a little bit more inspired. But before we wrap up at the end, we're going to do a segment that we always end on, which is the We Are the Sages segment. And so for this portion, we want to hear about your most memorable Sages moment.
We are the world. We are the world. We are the sages. We are the sages. Sing it, everybody. We are the ones who make it bright our day. So let's start treating. Have you had a good time tonight? There's a choice we make. We got a lot more coming. We are dancing.
Okay, so I'm really very glad with all the collaborations that we have with the European Association of Surgery. So I'm very happy to have been part of the collaboration on, for example, diverticulitis, on the anastomotic leakage framework, but also now on the sustainability committee, that we work on this very important item together. That I really appreciate that.
That's great. We are, again, yes, thank you so much, Professor Bouvy, for joining us on SAGES Stories. We do put some links in the podcast. So for our listeners, I'm sure it'll be very shortly, hopefully before. But if you're available to attend the EAES annual meeting, it sounds like it is in Belgrade, Serbia this year. Is that right? On June 17th through 20th?
Indeed. Yeah,
Indeed.
very
that's
happy to,
and that's when
to
you'll be handed the baton for the next year, correct? That's the transition for you, as in June of this year.
Yeah. So at the moment, George Hanna is the president from Imperial College in London, and I'll try to do my best to do the same things. Yeah.
I don't think you have anything to worry about there. I think the society is in great hands, and we look forward to seeing you either on this side of the ocean or in your side. Thank you so much.
Very happy to join SAGES again. Okay.
And that wraps up today's episode of SAGES Stories. You can view the show notes for any links to sites we referenced today. Visit sages.org for membership information and for the most recent news from our society. Follow us on Twitter at @sages_updates. Make sure you hit the like button and subscribe so you don't miss any future episodes. See you again next time, and remember, you can't spell minimally invasive surgery without SAGES.